Hello, my name is Jacob Welch, and I'm going to be analyzing the topic of anti-nuclear antibody testing, or ANA testing for short. Let's first begin by discussing what an anti-nuclear body is exactly. ANAs are often referred to as anti-nuclear factors. These are antibodies that bind to the contents of the cell nucleus or other cytoplasmic features. ANAs do not function like a healthy individual's and instead respond to the individual's own antigen. There are many subtypes of ANAs, and I have listed them here. Each of these antibody subtypes bind to different proteins or protein complexes within the nucleus. They are typically found in many different types of disorders, including cancers, infections, and autoimmune disorders, although they still can be found in some healthy individuals. ANA testing is used to detect antinuclear antibodies and generally has two components. For patients with a suspected ANA disorder, a screening ANA is ordered to detect the ANA regardless of the antigen specificity. Then, if the first test is positive, additional tests characterize the antigen specificity of their ANA. Identifying the antigen specificity has important diagnostic implications for patients. They can be used to diagnose many diseases such as systemic lupus, erythematosus, rheumatoid arthritis, Sjogren's syndrome, scleroderma, psoriasis, and cancers. They are also used to determine prognosis by allowing a physician to understand how the disease may develop. They can also be used to monitor an ongoing condition and guide therapy. There are three main types of ANA testing. These are indirect immunofluorescence, enzyme immunoassays, and multiplex bead immunoassays. Immunofluorescent tests, or IIFs, are the most common type of ANA testing. Hep2 cells are usually used as the binding substrate and are used to coat the microscope slide during testing. The patient's blood is then incubated with the test slide. If the antibody is present, it will bind to the cells, coating the test slide. Fluorescent dyes are then used to visualize the molecules under a light microscope. There are two types of immunofluorescent tests: indirect and direct. Direct involves the antibody being covalently bonded to a fluorescent dye. Indirect uses a secondary antibody with the fluorescence to bind the target antibody after it is already bound to Hep2 cells on the test slide. Both approaches allow for differently labeled antigens to be visualized using antibodies attached to phosphors with distinct emission spectra. Depending on the antibody present in the human serum, distinct patterns of immunofluorescence will be seen on the Hep2 cells. Levels of antibodies are analyzed by performing dilutions on the blood serum. There are four types of enzyme immunoassays, or EIAs. Enzyme immunoassays use multi-well plates to screen for specific types of ANAs. The mechanisms of the four types are depicted here. The upper left diagram is the direct. To the right of that is the competitive. Under that is the non-competitive. The lower left is the capture method. The common steps throughout is an antibody or antigen is bound to the floor of the well. Either an antigen or antibody is added to the mixture. If there is not already an enzyme labeled antibody present, one is added in the next step. The mixture is then washed, leaving only the bound materials behind. Chromogenic substance is then added, reacting with the enzyme, causing a color change. The color of the solution is proportional to the amount of antibody bound to the antigen. They are frequently used to diagnose hepatitis. Most EIAs are reported as a numeric value with an arbitrary unit of measurement. Multiplex immunoassay, or MIAs, are the third and final type of ANA testing. They use magnetic beads to simultaneously measure multiple analytes in a single experiment. Beads of specific fluorescent colors are coated with antibodies with specific binding circumstances and mixed with the subject's blood serum. The number of analytes measured is determined by the number of different bead colors. MIAs are reported quantitatively as ANA positive or ANA negative, with screen results being based on the collective assessment of all the individual's antigen specificities included in the assay. If all the included antigen specificities are negative, then the ANA screen is interpreted as negative. If one or more of the beads show fluorescence exceeding a certain threshold, a sample would be identified as positive. The only test with results up to interpretation is the immunofluorescence test. A negative result argues strongly against a diagnosis of an active ANA. This does not, however, exclude the possibility of other immune-mediated diseases. Greater than or equal to 1 to 40 is considered a low concentration. Low positive concentrations are often not specific for diseases. Greater than or equal to 1 to 80 is considered a high concentration. High concentrations, if accompanied by appropriate clinical and laboratory findings, can be used to diagnose a specific disorder. The high concentration alone would not be enough evidence to diagnose a specific disorder. Immunofluorescent patterns are also used to determine the ANA type. The four main patterns are homogeneous, peripheral, speckled, and nuclear. Homogeneous means the entire nucleus of the cell is shown, and not a specific one type of ANA. Peripheral means that only the outline of the nucleus is shown and is common in lupus cases. Speckled patterns appear as tiny dots throughout the nucleus and are indicative of a connective tissue disease. Nucleolar appear as two bright spots in the nucleus and is common in scleroderma patients. There are many differences between the three tests. Some reasons why you may choose to utilize one over the other could be due to the differences in specificity and sensitivity. IIFs are able to identify ANAs more specifically through the formation of patterns on the results, while the other two methods only yield positive or negative results. IIFs have been considered the most sensitive method for identifying patients with ANAs, since it is capable for screening antibody reactions with hundreds of nuclear and cytoplasmic antigens. The American College of Rheumatology identified IIF as the gold standard for ANA testing, primarily based on its high sensitivity. Dilution ratios of IIFs can be adjusted to increase specificity and at the cost of sensitivity. EIAs and MIAs provide a good balance of sensitivity and specificity. Automation is also an important factor when deciding which test to use. EIAs can be performed manually, although more often than not, labs perform this test on semi-automated or automated platforms. The semi-automated platforms may dilute patient samples and add reagents to the plate, but technologist intervention may be required to wash and move plates to an absorbance reader. A fully automated system processes EIAs in its entirety, only requiring technicians to load the samples. Most MIAs and IIF systems are also fully automated, but for IIFs, a technician is required to validate and approve the machine's results. The three tests also have an impact on workflow. MIAs have the advantage of being random access, which facilitates improved workflows. In contrast, EIAs are batched, which for labs with lower volumes of ANA orders could have a negative impact on workflow and turnaround times. These are my references. Thank you for listening.